chat, but plenty of my BHIPP colleagues will be monitoring that for us. And we're going to start off by talking about pediatric depression. Then we'll move to anxiety and have a break, get back to ADHD, and learn a lot from Dr. Parrish on some parent management. So that's kind of the overview of the day. So starting off with our pediatric depression, we're going to learn how to screen and diagnose in the primary care setting, become familiar with the non-pharmacologic treatments of depression that are really very transferable in pediatrics and information that you're probably already giving. And then specifically understand a little bit more if you do need to go to treatment with pharmacologic agents, how we do that. And so it's important to talk about, why we're doing this. We know that 1 in 5 children and adolescents have a diagnosable mental health disorder. That is about 8 million United States youth, about 10%. And the bottom line is that there's only around 8,000 child psychiatrists, and there's 170,000 primary pediatricians. And that includes all levels of providers. And so really primary care is usually the first and often the only contact. And so that's why we're here today to discuss this. It is you who really are treating the majority of patients. You're the first line, and you're obviously also in a unique position where you're trusted and you know our children and families best. You've been taking care of them since birth. And so it's really important that we help support and make sure that you have these tools necessary to identify pediatric ADHD, depression, and anxiety. And who says so? Everybody. The CDC, the American Academy of Pediatricians, and a family practice, and our child psychiatry professional organization. So it's really important. So starting off with pediatric depression, just a little bit of a review of the epidemiology. We do know that about 20% of teens will experience clinical depression, and this will happen before adulthood. So that roughly translates into about 5% of children and adolescents suffer at any given time. And when kids are younger, the ratio between male and female is about 1 to 1. And then as we get towards adolescence, it becomes a little more predominant with females. So about a 1 to 2 ratio. Looking at suffering from dysthymia, almost about 2%, about that 1.5 to 2%, you'll see different statistics. And then we do know that depressive disorders are appearing at a younger age. So it's important to kind of keep this in mind. So suicide is currently the second leading cause of death for youth ages 10 up to 24. And identification of early depression and symptomatology is important as we're looking at our suicide prevention measures. So what does it look like when youth come to primary care office? So sometimes the parents bring them in because they feel like, he's more irritable. This kid might be more saying depressed, depending on the age of the kid. We know that we're going to have cognitive presentations looking at decreased concentration, thoughts about feeling not so great, feeling worthless or guilty. Then also starting to, at times you can, first presenting issues sometimes really has to do with suicidal ideation. And then we have all of the somatic or the neurovegetative symptoms, saying that they don't have a lot of energy, feeling very tired, sometimes agitation, not eating as well, so you might see weight loss, or the opposite, eating too much, weight gain, sleeping not enough, sleeping too much, and then maybe not really enjoying the things that they used to do, that anhedonia. So these I put together in any of the slides that I've developed. Please feel free, you'll have access to them at the end, and I'm a very firm believer in sharing information. So any of the slides, if you ever need to go on and do presentations, feel free to always take anything from here. And this is a nice infographic, and that's why I highlight it, so that when you're giving psychoeducation around what are some signs that your child might be depressed, it kind of just puts it all together. So sadness, we're talking about that lasts most of the day, being cranky, For younger kids, a lot of times regressing in behavior, acting younger than their age, and then all those changes that we talked about with sleep and appetite. I'm not going to bore us by going through all of the DSM-5 criteria, but just to let you know that if we're looking for more than 5 of the 9 total symptoms, and it has to include a mood. So in children, it can be irritable and not just a depressed mood. So in adult psychiatry, when we're looking at the DSM criteria, it's a depressed or sad mood or with anhedonia. But with children, it can be more of that irritable mood. So that's an important difference. And here's, again, just highlighting all the things that we talked about. So let me go to a video, and hopefully this will work, that I think is a nice way to sometimes even just incorporating, showing families this psychoeducation is important.
In a teenager, is depression more easily identifiable in how I feel or how I'm acting?
So I think that it's both, but the sign for a parent is the behavior. So if all of a sudden your teenager is not doing the usual activities, is no longer interested in football, is no longer texting constantly with their friends, is no longer interested in the food that they liked before, or their sleep pattern has changed dramatically, or their attitude towards school has changed, those are all red flags. And I'm not talking about a day, I'm talking about 2 weeks where a parent says, there is something different. Now, certainly if a child tells you, a teenager says, I feel miserable, I feel like I wish I was dead, that is something a parent has to act on. I think that what all young adults and teenagers struggle with is impulse control and the intensity of their feelings, and simultaneously loneliness because of that self-consciousness. And so those kinds of impulsivity also affects the way they think. So they freeze, or they're boiling, or they hate you, or they love you. There's no like, there's no, that warm disappears. It's always boiling or freezing.
0 to 60 quickly.
Right, and in many ways, they're like a Ferrari with bicycle brakes. And so what you have to do with a teenager is wait them out. You don't minimize them. You don't say, oh, you're not freezing, or it wasn't the worst day of your life today at school. I mean, that's silly. You have to say, things like, how can I make it better? Or what was something that made you feel better at school today? Or can you tell me the worst thing? Maybe we can figure out a way to problem solve. Once you make the diagnosis of depression, the treatment choices we have are pretty impressive. So if you treat someone with cognitive behavioral therapy, that's a kind of treatment that's 10 or 12 sessions. A psychologist who's been trained in CBT knows how to use it. And basically the way we feel is affected by the way we think, which affects the way we behave. And if you could break that cycle, that's what CBT is about, and teaching someone that sometimes you have cognitive distortions, that you think you're ugly or you think you're unlikable, and that's your depression tricking your brain. If you do CBT for 4 weeks and the patient, the teenager, is not any better, then the suggestion would be continue the CBT, which is giving you tools, and add medication. And the medication you would add is something called an SSRI, a Prozac, Zoloft, one of those medicines that makes serotonin more available in your brain. Here's the best news: 71% of teenagers who have depression, who get 12 weeks of CBT along with medication, get better.
In a teenager, is depression...
Let me get to the next slide here. How do I get out of here? There we go. So I put that clip in because I went through, you can go through YouTube and find lots of different stuff. And I thought it was it's less than 3 minutes. So sometimes when you're meeting with a family, to have a quick clip to watch together is a nice way of doing it. To even say like, hey, here's a clip, go back home and watch this. So I think that's, just a nice quick 3-minute one that I put in there that gave an overview of all the different symptoms of depression. And then it did, for this talk, jump ahead a little bit with as far as treatment, but it also then talks about treatment. And so it's really important that, we're thinking about the best way to connect with families, to make sure that we're getting across the information and in the most palatable way. you guys are busy, families are busy, and so, having sometimes some video clips is a great, easy way. So that was a recap so far of just what are some of the depressive symptoms. And in that video, we highlighted, parents usually, so depression can be an internalizing, overall diagnosis. So a lot of times you're having those feelings and thoughts inside, but with kids, parents start noticing those behaviors, right? And so the irritability, the acting out. And so that's when a lot of times the families will come. Now, for primary care physicians and primary care providers, we want to be able to screen. So if somebody says, hey, I'm worried about him because he's been really irritable, we know that the American Academy of Pediatrics recommends screening. There's the GLAD-PC guidelines. And so the screeners that we typically use is the PHQ-9 for teens, and it does have the 2 questions about suicidality. And then another free open access screener is called the CES-DC. And I think that one is used a lot in psychiatry and mental health clinics, but it's also free and available and easy to score for primary care doctors as well. And so here is the PHQ-9 that's modified for teens. And, you can have the youth fill it out while they're waiting before you actually bring them in, if you know that they're coming here for concerns of depression. And it's easy to score. It's free. You can download that. And we're just looking at, you add up the total score, and you're looking at that scale between if there's none, and it helps you to rate the severity. And it's also important that we're always looking at what is the impact of functioning. So when you ask this, make sure that you have that these items are based on how have you been doing in the past 2 weeks. So in the video, it was highlighted. We're not just talking a day of feelings, a day of seeming like they're sad or moping around or some sort of externalizing behaviors, but we're looking at least 2 weeks that this is a little bit more pervasive. And then we really want to get to how is this impacting their functioning as well. Okay. Sorry, oh, there we go. I was having a problem. My keyboard was not advancing. So when we go ahead and we score that up, and we're going to then base it on the severity of symptoms and functionings. As I mentioned, as far as the mild is that 5 to 6 symptoms. The score, the moderate, is in between mild and severe. And then severe is when you have a lot of symptoms present and the function is clearly disabling. If they're having suicidal thoughts and they really want to die and it's gotten to a point where they have a plan, or sometimes, with depression being so severe, you can start to have psychotic symptoms. And so that's how we would categorize based on that. When you start seeing a lot of 2s and 3s, those are the positive symptoms. Ways to ask and get a little bit more about that is, to say, tell me more about that. Tell me more about how you've been feeling that you just really can't sleep, or that your thoughts are moving really quickly, or that you kind of have brain fog and you don't think as well. So just to make sure that it's great that they fill it out and then you can score it. You have that piece of information, but it's nice to go back and really see which ones are positive and try to get additional information from the youth. Make sure that you're also screening for other mood symptoms and comorbidities. We know that with depression, there's higher rates, especially if you start feeling depressed and anxious. Youth have higher rates of starting to experiment and use substances. So marijuana, alcohol, usually, kids, depending on the age range that you're seeing, it's very easy to get cannabis in our community now. It's easier to get and it's cheaper to get than other substances, definitely easier to get than alcohol. And so it's important to be screening for that. Do a good physical history, of course, and make sure that you're not concerned that this could be something due to physical illness like thyroid disorder. And then you're looking for other psychiatric disorders as well. So making sure you're doing a good screen for anxiety, which we'll start spending a little bit more time in talking about, as well as bipolar disorder, And then any sort of trauma. You should be asking questions regarding traumatic experiences and if anything else is going on. So I'll try to make this now case-based. Again, please, let's make it a little bit interactive, and we'll go through this way. So I have John D. So John is back for his annual 12-year-old checkup, and he's doing well in school, and his parents say, yeah, maybe he's fighting a little bit more with his parents and his siblings. His mother says, he's kind of moody. And often he's like, I'm just bored. And maybe it's been going on for about 1 month or 2 months. They're not really sure. There haven't been any problems in school. They notice that maybe he's not as into soccer as he used to be, which is really not like him because he loved soccer and he would watch it on TV all the time and follow the games, and he had certain favorite teams. He wants to play his video games all the time. You do your exam, you don't have any concerns about any abnormalities. He's early in puberty. You do your counseling information. You counsel about video games and relationships and family, puberty. And he's 12 now, so do you go ahead and screen for mood? You do your PHQ-9, and he scored a 6. He said he, endorsed feeling irritable, low energy. When you ask him a little bit more about, tell me more about that, he says, it feels like he's kind of letting his family down. But in general, his grades, he's still maintaining his friendships, no problems in school, his grades are still going the same. And so you say, okay, here's a case of mild depression. So what as the primary care doctor do you do? And what is recommended for the treatment of mild, uncomplicated depression is what we call active support and monitoring. And that is really engaging and seeing the youth on a more regular basis. So to see the patient on that weekly or biweekly schedule, doing some non-directive support, and that can be some supportive information. So explaining what is depression and how does that look like in a kid, and monitoring them for the symptoms, and really encouraging things like exercise, making sure that we have some behavioral activation, that we, so in his case, in John's case, we'd want to make sure that he is continuing to do the soccer, or at least get out there and move around. We know with youth, a lot of times they have what we call a reactive depression. So when you're doing things, and most of us, it's true, when you're up and you're doing things, your mood does feel better. And so that is an important piece. And then making sure you're counseling about sleep, that he's getting enough sleep and a regular sleep cycle, information about screen time, make sure that there's not too much screen time right before bed because that can impact sleeping. And so you're really going to be doing this psychoed and just kind of monitoring and having this on the radar. And, you're not jumping the gun and saying, okay, oh my goodness, we got to get you on an SSRI right away. So what happens to John D here? You're forming an alliance with the child, and you're kind of helping to address the concerns about mood, acknowledging that there is something going on, and providing a lot of that psychoeducation. You're counseling the patient and the family about the options. It is important when we start talking about depression, and as you know, as you're working with preteens and teenagers, limits of confidentiality. So to let them know, like, if he endorsed just smoking some cigarettes, you don't have to go in and tell the parents. It's when things start to become concern for danger, self to harm or to others, and that's when we would, go ahead and need to involve parents and the limits of confidentiality. Sharing resources, phone numbers for websites, handouts, that sort of information. It's nice at that time too to kind of save a little bit of, save yourself some hassle if you can get some release of information to help provide communication with the school and the school staff. And or if maybe John was starting to, his mother had already brought him to see a counselor. So that way you have that open door communication, and it'll save you a little bit of time. So here is more for the psychoed piece Here's another video that I think is a great way for the teenager to see this as well.
Do you feel like you just can't get happy? Are you finding you're pulling away from friends? Do you sometimes sit in your room in the dark, not even realizing how many hours have passed? Depression can affect anyone, especially teens. About 20% of all teens experience depression before they reach adulthood. That's a worrying statistic. When singer Will Smith's daughter, came out and said she suffered with depression, the comments at the bottom of many articles were attacking her, saying, "What have you got to be depressed about?" A lot of people don't understand that mental illnesses don't discriminate between age or circumstance. Often, depression is even more difficult to recognize in young people than adults, because as a teen, you experience so many changes at this stage in your life. But the longer you feel this way, the more likely it's going to disrupt your life and turn into a long-term problem. So Psych2Go shares with you 5 ways to recognize depression. 1. Continuous low mood or sadness. Do you often feel very sad and low for a prolonged period of time? If you're feeling this way, things that normally lift your mood won't bring the same joy and happiness. You may feel low or cry for no specific reason. It's a good time to reach out and talk to someone. 2. Being irritable or intolerant of others. Irritability can be missed as a symptom of depression, as you're often stereotyped as moody and irritable already. It's also a very common symptom of depression. Often you'll have a very short temper and snap at people you love for no apparent reason. If you notice a change in your mood, it might be best to discuss it with someone, a parent, a school counselor, doctor, or a friend. Even if you think you're just having a rough time at school, it might not be depression, but talking it out helps to get the whole picture. 3. Showing feelings of helplessness. If you're suffering with depression, you'll feel out of depth, like you aren't in control of your life. You can feel completely helpless and confused. While these feelings are normal as you go through changes in your body and growing up, be aware if the symptom persists for longer than a few weeks. Feelings of unhappiness, worry, guilt, being fearful, helpless, hopeless, or lonely could all be signifying that something more serious is wrong. 4. Increasing social isolation. Do you want to just be left alone? When you're not feeling like yourself and your mood is low, it can lead to social isolation. It can be hard being around people because you feel like you have to act like you normally would. This emotional strain can cause you to give up socializing altogether. If you notice you're starting to withdraw from people, talk to someone. Even if you feel you're just having difficulties with friends, it may not always be a sign of depression, but dealing with it now can help stop it turning into something more. 5. Little to no enjoyment of things you once liked. Have you lost interest in being involved in after-school clubs, music practice, or sports? Do you feel like you don't want to go and are contemplating dropping out? You might not even watch your favorite TV shows with as much interest. Not enjoying things you once liked could be a sign you're depressed. Have you struggled with depression? What do you do to help? Psych2Go would love to know. Be sure to leave a comment below. Thanks for watching. Do you feel like you...
Sorry about that. It always seems like once I have the video, I can't advance the slide quite as easily. So that I thought, and I did comb through a lot of videos on YouTube. I thought that was one of the nicest ones that was just a few minutes long that really hit all of the symptoms and done from that child perspective. So that I did have my teenage daughter watch it to see if she gave a thumbs up for, you know, how, if that was a horrible thing to watch or not. And she did say that that was a, you know, it was tolerable. It wasn't too cheesy. It wasn't too, she didn't roll her eyes quite as much as I would have thought. So she did give thumbs approval. So I'm going to stop for 1 second there because before we kind of get into other treatments And it really is a little bit hard to, I wish we were in person, you know. I'm so sick of Zoom calls and doing everything virtually. I wish I was in your area right now, being able to do this in person and kind of have that more interactive feedback. So let me just stop for 1 second so I can see everybody and check in to see where we're at and see questions and kind of go from there. Anything in the chat from the BHIPP team?
I had a quick question. I'm sorry, my video is not working. I'm trying to fix that. But at our practice, we currently just do the PHQ-2. And I was wondering your thoughts. And usually, if that's positive, we go to the PHQ-9. But I was wondering your thoughts of if that's enough or if it's more effective to just go right to the PHQ-9.
Yeah, I think the PHQ-9 is a nice way to get a handle and have that open dialogue. Even if a youth wouldn't score high enough, it's important that we're asking those questions. And so rather than just getting to the safety concerns, which would be the 2 questions there, I do think it's important, and it is recommended by the American Academy of Pediatrics and family practice physicians as well to start screening in the GLAD-PC guidelines. So to do the full PHQ-9, it doesn't take that long, and I think that a lot of times. So I can just, again, give personal experience. I know that my daughter's last well care visit, they just, they sent her the link through MyChart, and she was able to complete it before she even went to the visit. So a lot of times there's ways to have, so that it doesn't interfere with your workflow. I fully recognize you are so busy. You guys do and have to cover and are responsible for so much information in a quick 10-minute, 15-minute appointment, and how it can get derailed. And so I think sometimes the fear is like, oh, I don't want to open up a can of worms. But we know that if you can do this up front, the treatment and outcomes are going to be much better. So great question. Thank you for asking that.
No, I appreciate it. Thank you.
Anything else before I hop back in there?
I was just going to say kind of what you were just saying, Dr. Edwards. I feel like I need to remind myself to be in this mindset of when I see that abnormal screening at the start of the visit and I'm about to go in and do a well child and try and tackle all these different things, that I need to be very ready to just say, all right, well child will be postponed till next month. This is now a problem-based focus visit to focus on mental health, because it's just too much to try to do it justice and squeeze it in with everything else.
Yeah, you guys have so much. I mean, when you look at the list of what you're supposed to cover at all of your well care visits, it's just incredible. And it takes, the previous appointment that took a little bit longer, results are a little bit more complicated. Parents have more questions to just then kind of, I imagine, throw off your entire day, and that feeling of, like so overwhelming. So I completely understand, but that is a great mindset to go in to say like, okay, I'm just going to reframe. They can come back. We can handle the well care visit at another time. That's important. So thank you for adding that comment. And I really, my work as a child psychiatrist focusing on this is totally different timeline and focus than for primary care physicians. And so please, always let me know the best way and, teach us so that we can make this relevant for primary care. Because your timeline and scheduling and just, I'm so in awe of the breadth and depth of everything that you need to do. Anything in the chat, team, or not yet? Nope. Okay. All right. So let me continue on. Let me share this, and we'll go from here. Okay. We good? Can I get a thumbs up? Is it back on the regular? Yes. All right, thank you. All right, so John comes back. So we're still doing some active support, doing the risk assessment. He, at this point, at the time for the active support, he hadn't endorsed any sort of risk for suicide or suicidal thoughts in his additional questions. But, it's important just to let individuals know, give them those handouts that have the suicide hotline on there. If you need to do a safety plan, and we'll go through that in a couple of slides, we'll talk you through that. And so part of your specific treatment plan for him would be, figuring out goals as far as continuing his functioning in the home and with school environment, and then his peers, and we talked about lifestyle issues. So lifestyle, getting back to sleep, number one complaint for adults in our psychiatric practices, as well as frequently with kids, right? Teenagers want to sleep all day. We know this is part of their normal circadian rhythm that starts to change. And yet we still place unrealistic expectations and have them have to get up at 6 a.m. to get to school and be in high school by 7, depending on what's happening in your local area. So it's important that we're letting them know they need to have that regular sleep. Kids do not typically need treatment for insomnia, right? We don't need to start kids on sleeping pills and having that, just kind of giving them, they have agency over their sleep schedule. And so to give a lot of good psychoed regarding sleep hygiene. And before I'd ever recommend any sort of specific treatment focused on sleep, have them do a sleep diary. That's really important, because sometimes it's also perception of like, okay, it feels like it's taking forever for me to fall asleep. So they'll give you that information of like, I can't sleep, it's forever. But when you actually start mapping it out, because it'll say like you'll write down what time did you lay down. You can start to see that, their perception is really that it doesn't take them more than 15 minutes to fall asleep. So it's that kind of information that's important. No naps, that would certainly throw up your sleep cycle, and then caffeine, especially with all of the sodas and the energy drinks that the youth that everybody, they're very predominant in our society, as I'm drinking my coffee right now. And then for kids, the biggest thing really has to do with their phones, the electronics. We know the blue light impacts and does actually affect the part in the brain that will kind of throw off their circadian rhythm. So, if they can have that downtime, they need to have the downtime with no screens for, an hour before trying to go to bed. So assessing for suicide risk. So you have to ask for both about the thoughts or the ideation and then attempts. So the two questions of, have you ever wished you were dead or just go to sleep and not wake up? And then have you ever actually had a suicide attempt? Have you ever tried to hurt yourself, kill yourself, done anything to harm yourself? Or done anything dangerous where you could have died? Because sometimes youth have their scale of what, as long as their impression of what actually might hurt themselves or might not can be different. So these are important that you're getting at both. What are the thoughts that they're having? What sort of planning is going into it? And then what sort of dangerous behaviors or attempts have they had in the past? If you get to that point and active suicidality, you don't feel safe, send to the emergency room. But if you're treating and talking with a youth who occasionally might have a thought and it goes away and they don't have any plans, to sit down and have a safety plan, this is something that we can put a link. It's free. This is our safety plan here is what's used. We use it in all of the child psychiatry clinics. And it helps you walk through like the different steps. So it helps the youth understand warning signs. What are some thoughts or situations that would prepare, that lets them know that a crisis might be happening. And that could be things like fighting with my boyfriend, feeling left out if I'm not invited in a social situation. So those could be some of those warning They know that that's when a thought might happen, that they might have that thought of wanting to die or feeling that they're just not really that they're worthless. And then the second part of in the safety plan is, well, what are some things that they can do to take their mind off of it? And this is before you even reach out to get help. So helping to give them some agency over a thought is a thought. And so what are some distracting things that they can do? So can they listen to music? Can they go outside and take a walk? Can they exercise? Then the next part is, if that doesn't work, well, what are some people and social situations? So this is now when you are interacting. So not just trying to do it yourself and distract yourself, but then what are some situations and what are relationships that you can rely on and which would be able to provide that distraction when you're having this distressing thought. Then the next step is, okay, that's not working. And so who can I really reach out to? Can I call my friend? Can I call my mother? I usually try when you're doing the safety planning to have both a youth available who's somebody to reach out to, as well as an adult. And we help children problem solve around who are trusted adults who can help in these situations. And then, of course, the next step would be professionals. If they have a therapist, the suicide prevention talk line, they have a text line as well now. And then things to make the environment safe. So we frequently talk about gun safety, needing to make sure that any firearms are locked up and not easily accessible, as well as for families. Parents do not know that over-the-counter medications are just as dangerous as prescription medications. So a lot of times families will say, well, we have prescription medications in a lockbox, but they have the big thing of Tylenol that they just got at Costco sitting there on the counter, easily accessible. So talking about what are some other ways of making the environment safe. And then a really important thing is to have the youth identify at that time, what is one thing that's most important to me and worth living for. And so that is usually kids talk about their family or significant person in their life, and that helps bring it down. So this is a piece of paper that you can do. We have it now built into our Epic as far as depending on what your electronic medical record could be, but you can help complete this with the youth. All right, so you're still managing John, and you spoke to his mother at 2 weeks, and he's feeling better. So you're thinking, okay, great, some supportive stuff. This might have been a blip. He's doing great. He was sleeping better. But then 8 weeks later, his mother calls, and she says he does not want to wake up in the morning for school. She actually got a note from his teacher about missing some assignments. He's definitely having some outburst, going from that 0 to 60 out of anger at home. And it happened at soccer, which is really unusual for him. And some nights he doesn't seem to be sleeping at all. You wake up to use the mother says she wakes up to use the bathroom and she can see his light on. And again, that's really not like him. So you do another PHQ-9, and now the score is a 15. Before it was a 5. So we know that it's a moderate to severe level because it's impacting his functioning, severely impacting. And then the good news, though, is at this time he's not endorsing any suicidal thoughts or behaviors. And so at this point, you say, okay, this is moderate depression. So what do I do? Do I refer? And so the treatment for moderate depression from a primary care perspective, without kind of some of those complicating features, which would be more of the suicidal attempts or ideation, you can consider starting an antidepressant at that point and recommend some sort of psychotherapy. So in the very beginning, the first video, he mentioned about the TAD study. So we know that the treatment for adolescents with depression study, that youth who were treated with CBT, a course of CBT, and also received Prozac got better sooner. And so 71% responded, which was, that's an impressive number. And so you could, depending on if you feel comfortable, to go ahead and start an antidepressant, and then to see who in the area can be doing psychotherapy. The family might say, you know what, I just want to start with therapy, and that's okay too. The TAD study also taught us that CBT alone was effective in treating depression, but it was that both that helped. I'm going to actually have my colleague, Dr. Parrish, start talking a little bit about the psychosocial treatments for depression and CBT. Is it okay if I advance slides for you?
Yes, that would be great. Thanks, Sarah. Good morning, everyone. So just a little kind of like picking up the baton here. So we just had a consultation, I was thinking yesterday, and introducing the CBT model of treatment for a range of things, including depression, like Sarah's been talking about. So one of the things that we try to explain to kids and teenagers when we're introducing CBT is kind of pulling on their lived experience to make this seem very applicable to stuff that they already know about themselves. So it's not mysterious, it's not kind of strange, or this is only stuff we do for people that are different than everybody else. One of the things I actually said to a very bright teenager I had yesterday is, you know, we talk about this at the hospital. We wish we could give this to all of our graduate students and medical students to help them learn how to deal with lots of stress and pressure at different time points in life. So I gave an example. The kid was super into surfing, and I was like, well, you know, I like to go and take my kids to the beach too. And I looked at his mom and I said, but sometimes when I'm standing on the beach, I'm sort of doing like this scanning for sharks. And she was like, I do that too. And I was like, oh, okay. So she and I are both having this thought that, oh, there could be sharks out there ready to attack my surfing son. And that leads me to feel worried and nervous. And it leads me to engage in this behavior of kind of like vigilantly looking right for the sharks that might attack my precious baby. The kid is laughing. The mom's like, oh my God, that's exactly how I feel. And I'm like, so this is stuff that this model is already happening. Just normal times, like you're having a good time surfing and your mom is showing us like, when I look at things in a certain way, it leads me to feel a certain way, and then that affects my behavior. Sometimes it's a little harder to like help them see that how Sarah has the kind of double-sided arrows, that it's not always linear, like, oh, I have a thought, it leads to a feeling, it leads to a behavior, but the nervous checking can actually lead to a perception of risk and enhance or intensify a negative emotional experience or a positive emotional experience. So I feel like sometimes like doing that kind of basing it in an experience that the kid has kind of destigmatizes this as like this other thing that we only do for other people. So it kind of gives us an in for the other kind of CBT techniques that Sarah has on her slide now. So if we know that engaging in, for example, fun activities or being in fun situations leads people to have fun, be more entertained, or, you know, experience joy, and that does affect our view on things. So I said to him, like, you know, like your parents gave you all these surfing lessons. What if instead of you focusing on how much fun it was to be in the ocean and be like brave and confident and like do this really, like, surfing's hard. I've taken a couple of surfing lessons. I was shocked by how exhausted I got, right? If your coach had been like, okay, well, we're going to focus on this technique, but you really need to be paying attention to all the sharks that might attack you at any moment. But anyway, let's really kind of like start doing the surfing thing. It's going to fundamentally change the situation, right? And so how that interplay between what we focus on or what situations we put ourselves in, right? So like with the behavioral activation, we want to be increasing teenagers' fun, right? We want them to be engaging in activities that are naturally, intrinsically bring them joy, positive moods. The problem solving, so this kid in particular, his BMI is at the second percentile. Doesn't appear to have an eating disorder or anything, but he's like, well, you know, I just don't want to eat unless it's really good food. And if it's not good food, I'd rather just wait until the next opportunity. And at school, there's not good food. And plus it takes me 2 hours to eat. And so therefore, obviously there's nothing else I can do. I'm like, oh, okay, interesting. A little problem solving. Like, I wonder, you know, your sister, when she's at school, what is she doing? Well, she likes more things. Okay, I wonder if there's other things that you could like. Is there a possibility that problem solving, we could come up with alternative strategies and do a behavioral experiment and try those things out? Because it could turn out cognitive restructuring, that the way that you're looking at it, maybe there's a different way to look at it that might be beneficial to you because you want to have more energy and you see the impact of not eating during the day, what impact is having on your mood. So homework assignment, why don't we try to come up with a little experiment that you could try out where we try to add in one different thing and then just see how it goes. It's kind of cool to me, like how flexible the CBT model is. And like one of the things I said to him, this isn't necessarily a metaphor that will jive with every kid coming in. Obviously, I'm a bit of a science nerd myself. I was like, you know, I'm really into science. I really think science is real. You know, he was like, oh yeah, science is real. I'm like, cool. So we're on this like cool wavelength. Not everybody's going to feel like that, obviously, but I was like, I really like the scientific method. And that's why I like behavioral experiments, because it turns out that sometimes the way we interpret things at first is not necessarily the most helpful way to think about it. It doesn't mean that you're wrong, but it means there could be other ways to do it that are going to make you feel better. And that's sort of what I'm hearing you say, is that you want to feel better. Do you want me to keep going on this, Sarah? Do you want me to hand?
I think because for the anxiety part, you're going to focus, there's a lot of the CBT components. So this piggybacks though, as far as your homework assignment, being able to track with your behavioral activation. Let me see how many other slides there was, because I want to make sure I get to some of the SSRI stuff.
Absolutely.
Yeah.
I tried to give you a bunch for your one slide, so.
Yeah, no, this is great. Keeping them busy. So what something they can do, how they felt before they did it, and then how do they feel after. And it's great. The youth, the case example you're giving was able to really hone in and like the idea of like, okay, this is cool, science works, and I want to be part of that. This part, I think, let's get back to, I think we have the same slide when we're talking about the anxiety stuff. Okay, and the same thing with some cognitive restructuring as well. So we'll get to that in a second, and then let me do the SSRIs, and then we'll link back to some anxiety. So treatment for depression and anxiety, we use medications called serotonin, selective serotonin reuptake inhibitors. And these are tier 1 medications that you should be familiar with: Prozac, fluoxetine, Lexapro, escitalopram, Zoloft, sertraline. And I have a little video that explains how they work, because I think sometimes this is families like knowing, every family is different. Some people want a lot of
The
information.
human brain has about 10 billion brain cells. Each brain cell can have as many as 25,000 connections with other cells. Messages, which direct many functions throughout your body, travel through your brain from cell to cell through these connections. For these signals to move from a sending cell to a receiving cell, they must cross a small gap called the synapse. Chemicals called neurotransmitters, located at the ends of the sending cells, help the signal cross this gap. Serotonin is one such neurotransmitter, a very important one that helps regulate mood, emotions, and other body functions. After the serotonin has done its job, it's reabsorbed by the sending cell and is soon back in position to help with the next nerve signal. If you have depression, you may have a serotonin imbalance. Your overall level of serotonin may be low, and some of it may be reabsorbed too soon. As a result, communication between the brain cells is impaired. An SSRI, or selective serotonin reuptake inhibitor, is a medication designed to help increase the amount of serotonin in the synapse by blocking its reabsorption. As serotonin builds up, normal communication between cells can resume, and your symptoms of depression may improve.
There we go. So that's just a nice overview. Again, the whole point of, we have the synapse in between the two neurons, and so an SSRI allows it to remain in between that synapse so it can have more work before it gets taken back into the originating cell. So that's how that works, and I thought that was a good visual, nice little quick clip as well. And so SSRIs, and I think this is a great chart. This might be from Dr. I think from the Pediatric Psychopharm book, that if somebody already asked their question, if you're in the leading to go ahead and potentially get that freebie. So that's a wonderful book with Dr. Riddle and some of our other colleagues. And so looking at, families want to know, how safe are these medications? And so if we look at the SSRIs, and we also look at stimulants, so SSRIs have been on the market for over 25 years, stimulants over 50 years. The overdose, so what happens if somebody were to overdose on them? Very low potential. They're not, they don't have a high index if you were to overdose, and so relatively safe. And then we do have a black box warning for suicidality, which I'll talk about. But as far as long-term health risks, there's really none known. And so for something, they're approved for youth as young as 8. We know we do use them sometimes with younger kids, but that's a long time that we have been able to study, and there's plenty of data out there to show that the long-term health risk is low. The NRIs, or the norepinephrine reuptake inhibitors, same thing. They haven't been on the market quite as long, but again, long-term health risks, not so much. And so with stimulants, the biggest potential risk could be, potential drug abuse if used inappropriately. And then long-term risks, there is a little bit with the growth deceleration, which we'll talk about when we get to ADHD medications later in the afternoon. So which ones do we actually use? As I highlighted, kind of our first tier are Prozac, Lexapro, and Zoloft. They are FDA approved. So this chart is very nice that you can reference later because it says what ages they're approved for and for what disorders. So Prozac is approved for the treatment of depression from 8 to 17. And then we frequently will also use Zoloft, but it's actually only FDA approved specifically for OCD, obsessive compulsive disorder. Lexapro is FDA approved for depression and older, the adolescents 12 through 17. So we have the starting doses, daily range, and then the available forms. So Prozac, a younger kid, I'm probably going to start at 5 milligrams. And when I say younger, I mean like a 6 or 7-year-old. Teenager, I'd start at 10. And I'm going to slowly increase by that same increment. And daily dose for youth, if it's for depression, good dose is probably your 20 milligrams, sometimes 30 milligrams a day. For anxiety disorders, sometimes you need at the higher end, and so max daily dose can be up to 60, 40 milligrams for depending on the age. Lexapro, it comes in 5 milligram tablets, and so and 10, so you don't have as many choices. You start at your 5 or 10 depending on the age, and then increase. Max daily dose is 20. Although I must say in adults, and especially in psychiatry, we can sometimes bump it up a little bit to the 30. Zoloft, we can start for younger kids at 12.5. It comes in 25 milligram tablets, and you can half it. And or for a younger, more adolescent kid, I would start at 25 milligrams, and you increase at those same amounts. And Zoloft, you'll see a variety. I'd say for depression, an average adolescent depression dose, it's probably going to be close to about 100, 75 to 100. For anxiety disorders and adults, we definitely bump it up higher. And some adults, you'll see like close to the 200. So they both, for pediatrics, they come in capsules and tablets. And then there's liquid formulation as well. So that's important. And this is just a nice chart to reference. So some basic psychopharm rules that apply. You want to prescribe evidence-based treatments. Use the FDA approved when possible, and just be upfront with families. If you are using a medication that might be off-label, just let them know that and explain your rationale for that. We want to use as few medications as possible. And we're monitoring for, is it working or are there any side effects? And you never want to really give another medication to treat a side effect, because that's how we start getting into all the polypharmacy. You want to start low and go slow, but not too slow. And that's important. Sometimes we get referrals from pediatricians who started a youth on Zoloft, and they've been at 25 for 6 weeks. We can go ahead and help, we'll let you guys know to go ahead. It's safe to increase it. So it's good to start low, go slow, but just not too slowly. And then we're monitoring for safety and, any side effects. And you just want to be thoughtful, and when you're making changes, that you're kind of sequential in how you change your medications. So that's what I just said. And really important to recognize, So with stimulants, when we talk about ADHD later on, the effect size is great. It's wonderful. It's close to, it's about like 0.7, some studies, 0.8, 0.9. It's really, really impressive. For anxiety, SSRIs also have a higher effect size. It's about 0.7. For depression, it's definitely lower. It's about 0.2 to 0.3. You'll see some studies, because in depression studies, we do have a higher placebo rate, response rate, and we think that factors into it. And it's just going to be, if you're giving this medication, you want to make sure a youth is also receiving some type of counseling support. And if it's really, severe enough that it's requiring SSRIs, I would want the youth to be having that counseling, and also making sure that you're talking about evidence-based treatment so that it is CBT, because that's what we have. And the evidence for CBT and things for anxiety and depression, those skills that the kids incorporate last longer than medications, right? So it's something, if we can set you up and have those skills, and the youth are able to internalize and start practicing them early on, well, by the time they get to college and they start having, or placed in situations where it's stressful, right? And then they start having probably some cognitive distortions. If they can go back and start using the skills that they worked on, we're setting everybody up for the most success. Side effects in general we'll get to, but very minimal and reversible once you stop the medications. So this is important, that it does take about 4 to 8 weeks to reach a full therapeutic dose, and before you'll start to see maximum benefit. So unlike stimulants, where like when it's in your body, it works. When it's out of your body, it stops working. SSRIs take a little bit of time to build up, a couple of weeks, before you will start to see the impact. You don't really need any screening labs. I would recommend, especially for older adolescents, if there's concerns and other symptoms that might be suggestive of like a hypothyroid, to check for thyroid disorders. So we talked about how the onset is a couple weeks, and usually, though, any sort of side effects will happen earlier on in treatment, within this first few days to week. Serotonin, we have the most serotonin gut receptors in our gut, and so a frequent side effect has anything to do with GI. So kids complain of some belly pain, sometimes some loose stools. That's usually related in the beginning and will go away. We're going to see the therapeutic effects targeting all the neurovegetative symptoms of depression before we actually get to the mood part. So you might notice that a kid seems to have more energy and is more engaged and talking more to the family and is sleeping better, before the kid themselves might be able to say that their mood is feeling better. And as I mentioned before, these medications work as long as you're taking the medication. So if you stop it, it's not going to work during that time. There's really no guidance as far as, well, which one do we start? Do I start Prozac? Do I start Zoloft? I'm not sure. And so no specific guidance. If you are able to use one of the FDA approved ones, you should. Other things that we consider, an important one would be family response. So if the mother's with the child and she's like, I've always had depression and anxiety, and I responded so well to Zoloft. Usually for depression in a kid, I would start with Prozac, because it is FDA approved. But in that case, if the mother's had such a great response, you do the shared decision making to say, like, hey, maybe it makes sense then just to try Zoloft first. Considerations would also be half-life. So Prozac has a really long half-life, and I have some slides that will show that. And everybody, it's hard to remember to take a medication every day. And so for teenagers, if they're going to be responsible for their medication, and you think, well, they're not going to remember, skipping a dose of, when you've been on a stable dose of Prozac, is not as big of a deal because of the very long half-life. And then depending on any other medications, you'd want to look for drug-drug interactions. So there's nothing to say like, oh, you got to start with Prozac right away, or you got to do, oh, he's 12, let's do Lexapro. It's really taking in these other considerations. Here is a chart that you can reference again later about how to start and titrate. And I kind of talked through that with the other chart, looking at your starting dose, the increments that usually whatever you start at is the increment that you will do your dose change, and then giving the daily dose and again the available forms. Cymbalta is not a full SSRI, it's an SNRI, and so it's hitting a little bit more of the norepinephrine, and it is FDA approved now for generalized anxiety disorder in youth. So that's why I put that up there. I don't think a lot of pediatricians will be prescribing it, but I throw in this chart for your later reference. So what do we talk about as far as common adverse effects? As I mentioned, the GI stuff, because we have so much serotonin in our gut. So the nausea, not feeling so good, tummy aches, a little bit of loose stools. Especially in the beginning, some people do feel a little bit like keyed up, and so they have harder time falling asleep at first. Some, it actually can make people feel a little bit more fatigued and tired. This is important. There are sexual side effects with SSRIs, and nobody ever feels comfortable mentioning these things because we're also, worried about talking about uncomfortable topics. But it is important with our adolescent, especially adolescent boys, to mention this, to mention that it is a possibility. Usually it's not the first thing I'm going to lead into, especially if somebody's hesitant about taking a medication. But it's important that they know that there is a chance for this, so that you can see a little bit of decreased libido, sometimes an ejaculatory delay, or having problems with orgasm. Don't see it as much with children. With adults starting SSRIs and after they've been on them for a while, it is a side effect that is discussed a little bit more in adult practice. But I think it's important for kids, because for a teenage boy who is used to something and then suddenly it's not happening or it's taking a little bit longer, that's important. And if he's benefited from the medication, you want to have that open dialogue about risks and benefits. Some people do notice a little bit of sweating increase and tremor, especially if they're taking it on an empty stomach. Sometimes in the morning they might feel that way, and you can decrease the dose or make sure they're having a full stomach when they're taking the medication. And sometimes there is some agitation. So these are common. People talk about this idea of activation on an SSRI, and truly switching to a mania, bipolar switching, happens in about 1%. And that is when a true mania is, elevated mood, grandiosity, absolutely no need for sleep, not just like problems falling asleep, but like up and feels like they're not tired, and just that true grandiose and mania. And that only happens in about 1%. So it's not at all a common thing. Activation is, you kind of think of like a Benadryl reaction for some kids, how they get a little bit more hyped up on it. That can be how I look at activation in kids. Usually it's dose related, so you can back down in it. And it's kind of that just feeling a little bit like you've had too much caffeine reaction and problems falling asleep. It is reversible, and there's really no sort of long-term prognostic implications with it. Safety concern and monitoring. So you don't want to use SSRIs with MAOIs. Most people aren't prescribed that, so it's not much in there, but we always throw that out just to make sure that you're aware of it. We do know that SSRIs impact platelet functioning. So sometimes there's very rare abnormal bleeding that can occur, the very rare activation of mania. And sometimes people initially lose weight, some others it seems to increase their appetite, so you're just monitoring for that. And then talking about, yes, we have the black box warning for suicidal thoughts and behaviors. And it's really important that you recognize that when the FDA did first came out with this, it was never that there were increased deaths by suicide. It was the term suicidality, so increased thoughts and behaviors. So that's important for families to know. Then we put out the black box warning. What happened was prescribers were like, I don't want to prescribe this anymore if this is what's happening. So it's a very small percentage of kids that may have, in the beginning of starting an SSRI, some increased thoughts and or some behaviors, but you're going to be monitoring for that. And so when this came out and then our rates of prescribing SSRIs went down, we actually know that that trended at the same time with increased deaths by suicide and increase in suicidality. So it's something that you have to talk about. You're going to ask and monitor, but it is not something, when you look at the risks and benefits, we know that these medications are safe. And it's super important that if a youth needs an SSRI, that they receive this treatment. So more about the black box warning. Again, that point is really important about there were no increased and completed suicides. And all studies show, reduction in suicidality when you're going through the full course of treatment. So SSRIs in general, are associated with lower suicide rates. So it's important that, as I mentioned, individuals are receiving this treatment. You got to balance it. How do you monitor therapeutic response during these adjustments? Sometimes a weekly check-in. Now it's depending on your standardized or your electronic medical record. You can shoot a quick message to the patient and they can message back or to the family to see how are they doing as you're checking in with them. And then when you're seeing them again in person to continue to do another PHQ-9 is a nice way to kind of get that objective data about their response to treatment, to SSRIs. Follow-up schedule. This is pretty, this is what's, recommended. It doesn't happen all the time. No, and I think everybody understands that. But after starting an SSRI, you should have face-to-face contact at least within that 1 to 2 weeks. Things are different. If they have a therapist, and they're seeing that therapist on a weekly basis, that helps you rest assured that somebody is checking about that suicidality on a more regular basis. So this is where having that communication and making sure you have good continuity between providers and collaboration is very, very important. So if they're doing well, the follow-up schedule is, at least weekly. So for the first month, the actual for our ACAP guidelines would be that you're seeing the physician or therapist every week for a month. And then during the second month, every other week. And then after that, it's monthly. When you change a dose, to see the patient within 2 weeks. These are very stringent guidelines. This is kind of the absolute, the highest level. And I think just making sure you're having that check-in, knowing if they're seeing a therapist, that person is doing a lot of the checking in regarding the suicidality, that's important as well. I don't want to scare people off because these medications are so helpful. And we know that treatment with these meds decrease suicidality in the long run.
Dr. Edwards, I did just want to jump in for a question in the chat.
Yeah, great.
So you had mentioned go slow, but not too slow. Is 4 weeks a decent time frame for when to consider dose adjustment, still knowing that full effect of original isn't completely seen yet?
So it depends on, I would, at this point, if you're using a medication, they probably have that moderate, level of depression. And so if you're going to see them, if you happen to see them, because your schedule, you guys have very busy schedules, the first appointment that you're going to see them is in 2 weeks. If you're starting at something like Zoloft 25 for a young youth, at 2 weeks, I would increase it to 50. Okay. But maybe it's been a month. And so you kept them on that 25 and that's okay as well. Have the family call in though, right? Or to contact you. Like if after a couple of weeks you're noticing nothing, or more importantly, symptoms seem to be worsening, that's when you want to try to have that dose increase sooner. So I'd say a couple of weeks, between that 2 and 4. A lot of this really depends on what your schedule is, and or how much contact you can kind of have and have your nursing staff or through the medical record, that connection as well. That's a great question. So there's not this strict guideline. You have to wait 4 weeks before you increase it. No, that's okay. You can start, if you start at a little bit of a higher dose, like if you started at, I don't know, I'm just saying, if they started at Prozac 20 instead of Prozac 10, then I'd probably give that more time before I'm going to hurry up and increase it. If they haven't developed any side effects and that's just kind of what you had already started them at, then that's okay to wait a few more weeks. More questions about that? All right, that I had already kind of touched on and don't want to spend too much time on drug-drug interactions. Just remember that both Prozac and Zoloft are metabolized by 2D6. So if there's other drugs, if the kid is on a lot of different medications, you'd want to look for that drug-drug interaction. What happens after, let's say, you have decided they're now on a good dose, they're on Prozac, you've taken them up to Prozac 30, and you just really don't think, they haven't seen anything, and you've decided that this isn't, they're kind of frustrated, it doesn't seem to be working. Usually people subjectively will feel something, and sometimes that something too has, again, these medications are going to work first on more of those neurovegetative symptoms. So the energy, the better sleep. Families frequently just notice that the kid's more interactive, like willing to kind of talk to them more or be present in the family setting more, rather than that isolative part, not as irritable. So usually that you will see something within the first couple of weeks, not the full effect, but you'll see something, or that they will feel something. And if they didn't feel anything at all and you've increased to a pretty good dose, the question becomes, what do I do? Do I go to a different type of medication like an SNRI, or do I try another SSRI? And we know that the research, the Tordia study shows that you go and you do another SSRI. So how do we switch? So again, here for the Tordia study, that if you fail the first one, go ahead and do another one. You could do a staggered and overlapping approach, and I'll show you some charts that help highlight that a little bit better. And that'll happen over the course of a couple of weeks. So here's an example of an 11-year-old with depression, and they were on Zoloft up to 100 for 6 weeks, and there was really no side effects, but there's no change in any of the neurovegetative symptoms as well as the mood. And so if they were on Zoloft 100, and you said, okay, I'm going to switch them to Prozac since we started with Zoloft. So you would, here is over the next couple of weeks how you could do that cross tapering, right? So you would take the Zoloft 100 and go down to 75, at the same time starting Prozac 5. And then in weeks 2 to 3, you'll increase the Prozac to 10 and decrease the Zoloft to 50. And then decrease the Zoloft to 25, increasing the Prozac to 15, and then your stop. And so that's how is a nice way to look at how you can do the staggered switch. And I know a lot of times we get many phone calls on BHIPP regarding this, because you're a little bit worried, like, do I just stop the Zoloft completely and start the next medication? And this is a way that you can do a nice staggered approach. Here is something to remember. I highlighted that that Prozac has a really long half-life. So if Prozac is suddenly stopped, you can increase, you can still do decreasing it, but you can do it a little bit faster because of that long half-life will cover you. But here's another staggered approach with switching between, say, Prozac and Lexapro. So you're stopping the 20 milligrams because then here in about 1 to 2 weeks, its half-life would already be at about 10. So the Prozac 20, the problem with Prozac is that it comes in capsules, so you can't half a capsule. If they happen to be on tablets, that's fine, but most of the time we're giving them capsules. So the primary doctor is like, do I want to write a new prescription for 10 milligrams? And you can, or you could literally just stop it knowing that it's auto self-tapering out of the body because of the long half-life. So Prozac is one where I don't worry as much about as far as doing a staggered, because it's doing it for us in its natural way. The norfluoxetine is the metabolite of fluoxetine, and it's like its half-life is days. So it's really a really long half-life. How long do we treat for depression? It's important to realize that once medications are working, we don't just want to stop. A lot of times, family members are just say, I only want them to take it, for a little bit of time. You really want them to stop the keep on the medication until symptoms have abated, and at least 6 months, but we recommend really about 9 months or a year after. We don't have to, families do not need to go into this thinking that forever, for the rest of their lives, they need to be on medications. It's going to be that open dialogue about discussing where the symptoms are and involving the teenager and adolescent themselves. Sometimes prescribers forget to take them off or have that conversation. They might be seeing somebody for years, and maybe their depression was so severe and they are taking it and they don't want to rock the boat, and that's okay too. But it's just, you have to check in. And really, again, you don't want to start a medication and think they're on it for the rest of their life for depression or anxiety. It's different when we talk about different psychiatric symptoms or syndromes. So here's a more med specific. Now, is this one, Chelsea, that we have as a poll question?
So if folks just want to enter their answer into the chat.
We'll do it that way. Okay.
Yeah.
All right. I wasn't sure. So we have a nice youth, Lashandra, and she's 17, and she was recently diagnosed with depression. The mom called and reported to your nurse that she expressed some SI, and this was while we were starting to titrate Prozac. So what would we do? Would we tell her to stop taking the medication immediately, go to the emergency room? Would we say, okay, I'm going to call her back, I'm going to talk to her and to the mother and get some more information regarding those safety concerns and really, tease out what are suicidal thoughts, planning, actions? Are we going to do nothing because we know that suicidal ideation is likely to pass in the context of our Prozac titration? What do you guys think? So wait, do I have to get out? I don't know if I can see in the chat, or you guys can just say some stuff out loud.
We're seeing a few B responses come in.
All right, good job, guys. Yes. So it's I'm sure very anxiety provoking if you suddenly, the nurse tells you, oh, you just started this youth on medication and now she's having suicidal thoughts, and your knee-jerk reaction might be like, okay, just have her go to the ED. I can't, I'm busy. I have 50 more patients to see today. This is kind of overwhelming. But really, we need to get that additional information. So there's no need to, at that very moment, unless she's actively suicidal or just had a suicide attempt, right? You want to get the call back and speak to the youth, talk to the mother, and get more information, and go back to those questions that I talked to you about, like asking about the thoughts as well as asking about the suicidal behaviors. Maybe it's like she had a thought about, she'd be better off dead, and she's not thinking that at that moment, and she realizes that if she has it again, she's going to talk to her mother, which is what she did the first time. You can bring her in, you can do more rating scales if you have another sick appointment in the next day, but you don't want to do nothing, right? That's an important piece, but you also don't have to immediately just say, go to the ER, stop taking the medication. So I guess, as I had already mentioned, we're going to talk it through. Active suicidality, absolutely. Call 911, have them go to the nearest emergency room. And that's when they're not willing and they're not able to engage in any sort of safety planning, or maybe they did something just at that recently to have some sort of self-harm. But if there really weren't any of those safety concerns, you can continue to monitor. They can stay on it. You're going to review that safety plan and hopefully, see them back in a day or two. You can say, my nurse is going to call you tomorrow to check in. Make sure you're not having any more increased thoughts or suicidal actions and behaviors as well. So it's important to monitor, and this would be a patient that you would want to then be having more of those regular appointments with or contact, right? So now she's taking Prozac 20 to target her anxiety and depressive, and it's been 4 weeks, and we've seen increased improvement with her sleep and concentration. Her mood is only slightly improved. So at this point, it's reasonable to continue the medication as long as the patient is being monitored closely. And if you start feeling uncomfortable at any point, reach out to BHIPP, or it's also, if you have a colleague, a psychiatrist in the area who would manage the youth's medication, it's also okay to do that. We have Dwayne, he's 16 with a history of anxiety and depression. He's becoming more anxious and activated after starting Zoloft 25 for the first week. Do we have the nurse call back and say, stop taking it? Do we tell him, oh, just go to the emergency room? Do you bring him in or talk to him and discuss what are some adverse effects expected of medication? Also, maybe see if there's additional stressors going on, screen for the suicidal ideations, or don't do anything because all of this will go away. What do you guys think? So this is basically a question of like, maybe there's some activation and I'm a little bit concerned.
Lots of C's coming in for this one.
Very good, right? So when you have some concerns about activation, you know, you can decrease the amounts and you can also then just titrate slower. And so that is on here, just clicking out of that thing on the screen. There we go. That is a way that you can handle that as well. Did I stop sharing? Are you guys still seeing?
I can't see your slides now.
Okay, yeah, I don't know what happened there. There we go. Is it back?
Yep, back.
Okay, great. So that's just another case. So he comes back in, and during the visit, you learn he is having some problems falling asleep. Oh, that's the one that we just did. Nope, sorry, this is another one. Okay, so he comes in, he's having problems falling asleep. He just feels a little bit jittery, but denies that there's any stressors or safety concerns. And so you say, do you instruct him to half the dose and stay on the 12.5? Do you just stop it because he might have bipolar disorder and he shouldn't be on antidepressants? Do we start giving some Ativan to help with the anxiety and jittery feelings, or do you do nothing because, again, it'll go away? But I think I kind of already combined these two here. But he can, you know, instruct him to half the dose if the beginning dose was too high. If he started at 25 and he was feeling that way, you can tell him to take a half a tab and just go a little bit more slowly with the titration. And I'm going to stop there.